Thank you. Hello. Good afternoon, everybody. Good afternoon. My name is Ashish Jha. I'm the Dean of the School of Public Health at Brown University. I was going to say here at Brown University, but we're in D.C., and we're excited to be here at the National Press Building for this event. And I want to spend a minute talking about what has brought us together. I will talk a little bit about this center on advancing health policy through research that is led so ably by Andy Ryan, who's walking in with a beverage in hand. And then we'll get into the meat of the conversation. You know, there feels more and more like there's less and less that we all seem to agree on in Washington. But the one area that I have found over the years an incredible amount of convergence and just sort of belief, if not, and I think driven by a lot of data and facts, is that competition in general is a good thing. That competition in markets lead to more innovation, continuous improvement, and the main beneficiary of that competition is the consumer. Now, if you apply that and think about that to the healthcare system, there's lots of complexities and lots of ways in which that doesn't quite work as well as we would like for it to work. And the reality of the US healthcare system is it's extraordinarily pricey, and the quality is not where we want it to be. And a lot of the work that I had done in my previous part of my career when I actually used to do academic research before I became a mid-level bureaucrat, was focused on the role of competition on quality in the hospital market, with the idea that you could measure competition and consolidation quite effectively. You had these economists who would come up with these things called HHI, and you could look at number of players in the market, and you could look at how much market share everybody has, and you could do this calculation. And it was fantastic. And in the last decade, we've seen a whole different way of consolidating that is much more about vertical consolidation or vertical integration. And whether something is consolidation or integration is very much driven by what side of that partnership you sit on and how you want to discuss it. So we find ourselves with a very different set of challenges, and I would argue that we were thinking about 10 or 15 years ago. If there is one innovation in the US healthcare market space, it is the ability for people to figure out how to consolidate in new ways. And I think that while there continues to be a lot of interesting innovation in healthcare, I think all of us would agree that continuing to spend 20% of our GDP on healthcare, still leaving about 25, 30 million Americans out of the health insurance system, having another 40 to 50 million people who have to pay large amounts out of pocket in ways that are very financially ruinous or certainly complicated, is not the system that we need. So at Brown, a few years ago, we launched a new center called the Center for Advancing Health Policy Through Research. Recruited Andy Ryan from Michigan to start and run that center. And in the last 3-4 years, how long have you been here, Andy? 3? Just about 3. It has become, and I am a slightly biased observer of this, the best health policy research group in the country. And they've done it by bringing in people with very different skill sets, and you're going to hear more about that. And this is an event to really talk about this issue of vertical integration, and I'm very proud of the work that CAPER's been doing in this area, but we're going to hear from a group of experts who think about these issues from a variety of different perspectives. Before we get there, we're going to have 2 keynotes. One is, even though I work in Rhode Island, I live in Massachusetts. So one is going to be from a senator from Massachusetts, Elizabeth Warren, who has been very, I think, doggedly focused on issues around consolidation in lots of different markets, not just healthcare. And so I think we have some remarks from Senator Warren before we move on to our other keynote. So somebody want to tee up the video? I can't see if it's playing.
Hello, I am sorry that I can't be there with you in person, but I am grateful for the opportunity to join you for today's event on vertical integration in healthcare. I want to start by thanking everyone at CAPER and Brown University School of Public Health for your powerfully important work. Research is key to my work in Congress, fighting for a more competitive and equitable healthcare system. Your insights are helping to shape healthier futures for families all across our country. One of the toughest fights ahead of us is the growing power of monopolies in healthcare. Part of that is hospitals becoming bigger hospitals and PBMs becoming bigger PBMs. But we're also seeing more insurance companies gobbling up physician practices and more PBMs snatching up pharmacies. In other words, we've got a system where too many companies are operating on both sides of the healthcare transaction. It is a gross conflict of interest, and the longer we allow these companies to control every link in our healthcare system, providers, PBMs, pharmacies, insurers, the more families are going to be priced out of life-saving care. Look, I know I don't need to convince this group, but if we're going to stop pharmacy benefit managers and giant insurers from jacking up prices on patients, from overcharging our government, and from squashing competition, then we've got to start by laying out the problem front and center. So, how do we stop them? Well, first, I have a bipartisan bill with Senator Josh Hawley and Representatives Diana Harshbarger and Jake Auchincloss to break up PBMs that own their own pharmacies and to untangle the corporate healthcare giants that are destroying our healthcare. Second, my Corporate Crimes Against Healthcare Act will stop private equity from squeezing our hospitals, our doctors' offices, and our nursing homes for every last penny. What we saw most recently was Steward in Massachusetts. And lastly, we need CMS to crack down on abusive practices in Medicare Advantage that let these giant insurance companies shovel more taxpayer dollars into related companies, possibly violating federal requirements. And we need the Federal Trade Commission and the Justice Department to step up and get serious about reviewing mergers in the healthcare industry. Competition is the best way to lower costs and improve care for patients. So yeah, these are bold proposals, but this is a righteous fight. And the time for tinkering around the edges in healthcare is gone. We need to stand up for patients and be honest about the problems in our healthcare system, and that is where your work comes in. This moment demands fearless research. In a moment where we're seeing reckless attacks on science and basic research, your work is that much more important. So I am grateful for your partnership and for your commitment to healthcare that works for everyone, and I will keep fighting for you in Washington. And I just want to say one more time, thank you again for having me. It is an honor to fight alongside you.
All right, fantastic. That was Senator Warren. And one of the points that she made that I think is really important is at moments like this where I started off saying we all agree competition is important, competition has all these benefits. It seems like the policy path is very forward. Let's just have more competition. And everybody agrees with that. But then it gets more complicated when you start thinking, well, how do we measure competition? And what are the negative effects? And are there any benefits to all this stuff? And how do we do this in a way that is thoughtful, methodical, legal? And that's where evidence and data come in. And I think too often we decide it is a righteous fight. We do want more competition. But then to translate a righteous fight into really smart policy that's going to make a difference, you need to be driven by data and evidence. And that is the role of academics. And when they're at their best, and which I believe the folks in CAPER really are, they're doing the kind of work that helps shape policy decisions that are going to be made by political leaders like Senator Warren and Senator Hawley and my Congressman Jake Auchincloss, who's been very, I think, strong on this issue of PBM consolidation. Let me get to our second keynote speaker, Jonathan Kanter. For those of you who've been in this space, he's not somebody who really needs an introduction, but I'll say very briefly, he recently stepped down as the Assistant AG, Attorney General in the Antitrust Division of the Department of Justice. If you look at his career, he's been in private practice for many years, He was at the Federal Trade Commission. The one through line of all of his work has been really thinking about the legal system's role and using the legal system to drive more competition in the healthcare space. Probably beyond healthcare too, but certainly that's the place I know his work the best. And so he was, as I said, served under President Biden at the Department of Justice. And Jonathan, we're really just thrilled that you were willing to come and spend some time with us and talk to us about these issues. So, Jonathan.
Well, thank you, Dean, and thank you to the Brown School of Public Health and CAPER. I think it speaks volumes about the role that Brown School of Public Health and CAPER play in this conversation as thought leaders, and the ability to really put their finger on the pulse, pun very much intended, of the issues that are most important in our policy discussion. I want to start a little bit with perhaps a call to action or a task, one that might sound easy, but I think is desperately needed. And again, to stay in the territory of bad puns, I think it's time for us to map the healthcare economy genome. And so I want to explain what I mean by that through a little discussion here. But the world that we find ourselves in today as a healthcare system and an economy is dramatically different from what we experienced just even a few years ago, let alone 2 or 3 decades ago. I know I grew up in a world where you had a doctor, you go to your primary care physician, you knew their name, right? They probably treated your entire family and your community. If you got really sick, you might go to a hospital. You might have an insurance company. You would have a local pharmacist, and so on. And all of these were separate entities. You knew some of them, you didn't know others. You mostly dealt with your local doctor. But then something changed. That was consolidation. And the healthcare economy shifted. It shifted from an ecosystem that was focused primarily on providers, and it shifted to an ecosystem focused on payers. And a world where the biggest question wasn't how are we going to make someone better? The biggest question was how are we going to make it less expensive? And how are we going to figure out who is going to pay and how much? The physical distance between the physician, for example, and the patient may be inches, but in today's healthcare economy, it might as well be miles. There are too many intervening events, actors, and players that now sit between the physician and the patient. And that has made our healthcare system worse. It's made it less personal, and it has led to a path that is ultimately a race to the bottom. And so part of what we need to do as a policy community, whether it's through research and academia, or folks here in Washington who are on the front lines, or the important bipartisan bill that Senator Warren discussed, is we need to figure out how to better map our policy to the realities of today's marketplace, to the reality of the way information flows, care flows in the modern healthcare system. And to do that, we need a clear picture of who is doing what, who owns what, and who is being paid what and when. And I have to say, we don't have that. It sounds so basic, right? Just a visual of what does it look like. We don't have that. We don't have one that is accurate to today's economy, accurate to today's system. What we do have, and what we've amassed over the last number of years, are a small number of unavoidable healthcare intermediaries. We used to have a world of horizontal competitors and vertical relationships. And then we had mergers. It might be mergers among providers to get more leverage against payers, mergers among payers to get more leverage against providers. But then that changed again too. And we moved from a two-dimensional vertical horizontal world to a three-dimensional or multi-dimensional world of healthcare platforms. So what do I mean by a healthcare platform? What I mean is a multi-sided intermediary that isn't just providing a service to one side of the market, an employer or Medicare to the Advantage to the federal government, or Medicaid to the state government, or a provider providing service. We have a world where one entity is providing all of that. But it's deeper. It's more nuanced. It's not just about delivering services to multiple sides of the market. That we have experience with. That might be a two-sided market. It might be vertical integration. But we have networks and platforms where you have to plug in to that platform. Look at some of the big healthcare companies. The biggest healthcare payer in this country is now the largest healthcare provider in this country. You have a PBMs that own pharmacies. You have these massive conflicts of interest. You can't participate in the healthcare system, whether it's as a provider, as a payer, as a data warehouse, analytics, without plugging in to one of these companies. And there are only a small number of them, and they are built on scale. And as data becomes more important, as we can start outsourcing care decisions, payment decisions, processing to algorithms, machine learning, and AI, we are going to be more dependent on a smaller number of players. And the sooner we adjust as a policy community to that market reality, the sooner we can actually start developing practical, pragmatic, effective solutions that actually work. But I'm sad to say that we are stuck fighting the last war. We are stuck having conversations about what the market used to look like. We are stuck coming up with policy decisions that are mapped to the healthcare system as it used to exist. But what we all know is that things have gotten worse, not better. The level of care is down. It's more expensive. It's impenetrable. And it's going to get worse before it gets better. The cuts that are coming to areas like Medicaid are going to make it harder for independent physicians to survive, for providers to exist as independent businesses, small businesses, pillars of their communities. And they're going to go out of business. And they're going to either disappear or most likely get acquired by these large mega platforms, either directly or indirectly through other organizations. Private equity is going to continue to roll up our provider systems and our payer systems. We're going to find ourselves increasingly accountable to a world, a healthcare system of these dominant, small number of dominant platforms. So again, what do we mean by platform? Multiple sides, essential infrastructure, often direct or indirect network effects, a system where the value to the platform increases as more people use it. And this is really important. We're not talking about closed ecosystems. We're talking about ecosystems, let's say a payer or provider platform, that the more people that participate in it, the more valuable the platform gets, the more indispensable it gets, the harder to avoid. But what does this mean for competition? Well, first of all, this is a reality that I saw in big tech, where we had a lot of experience in the antitrust world challenging these big companies. The bigger the platforms got, the more feedback effects, the more powerful their gravitational pull, the harder it is for anybody to compete. When the only way to compete is to compete at multiple levels, at massive scale, the number of players that is actually able to participate reduces. And so you see a trend toward acquisition and consolidation and concentration. You see vertical integration and massive barriers to entry. You see these massive companies understanding that what threatens them most are the disruptors, the folks who want to come in and not just rely on that platform, who not want to feed the monster. And so they either get excluded or gobbled up. We see regulatory manipulation and circumvention. We have sensible rules in some places, things like the medical loss ratio, that are becoming circumvented by vertically integrated entities. And so if you own the provider and the payer, then where you book the revenue and how you charge yourself changes the effectiveness of the medical loss ratio and undermines the system that we've created. We see cross-subsidization, where the money is being moved to the parts of the ecosystem that are least competitive, and so that, again, in order to compete at any one level of the system, you have to compete at all of them. And finally, as Senator Warren mentioned, we see massive conflicts of interest. When you used to be a world where you had payers and kind of providers duking it out, and while it might have been ugly, it was still, you had agency. You had one side saying lower the price to the other side saying we need more to do more. Now they're the same company. And as that phenomenon increases, it's going to get worse, not better. And those conflicts of interest are going to result, just like it did in tech, in the intermediaries becoming the regulators, not the government, but the decisions that are being made by these large healthcare intermediaries that will be made for the best interests of shareholders rather than the best interests of patients and the healthcare system. So that's grim. And we have a lot of work to do. You have a lot of work to do. And I'll finish where I started, which is, in my view, we cannot, as a community, effectively address that unless we finally wake up to the reality of how the platformization of healthcare has transformed the economy, has transformed the realities of healthcare delivery, and we can't have developed the policy solutions, prescriptions, and legislation we need unless we finally map the healthcare economy genome, we finally understand exactly how those market realities work, and then build the solutions that reflect those realistic market realities. So I'm really thrilled to be part of today's discussion. I can't wait to hear from the panel. And we have our work cut out for us as a community, but there are a lot of great minds, many of whom are in the room today, who will be right on it. So thank you very much.
All right, that was fantastic, Jonathan. Thank you so much. And I love the idea. Two things. I love the idea of mapping out the healthcare economy genome. Along with it needs to be a related thing, which is mapping out, so this is a friendly amendment, healthcare delivery genome, because part of what has happened in all of this is healthcare has gotten dramatically more complicated in the last 30 years. And much of that, by the way, is a good thing. Like, we're able to do extraordinary things we could not do before that requires lots of specialists, lots of technology. And on one hand, that's been part of what has driven the healthcare getting much more complicated. It's also been a fig leaf that people have used to engage in bad behavior, saying, oh, we're just trying to deliver much more complicated care. So you can't ignore how much more complicated care delivery is now than when I went to medical school in the last century. But at the same time, and that may mean that we may never get to a delivery system that's as simple as what we had 30 years ago. But that's also not an excuse not to take on these issues because, as you said, the platformization of this really has, and it's actually a much better framing than any other I've heard. So thank you for that as a way to think about this. Last point I'll make, and then we'll move on to our panel, is a point I've made in many of these conversations, and I feel bad for like Jared and Andy who has to hear this every single time I stand up, but I'll say it. This is not like just the most important health policy issue of our time. This is I would argue, one of, if not the most important social policy, overall policy of our time, because when you get to spending 18-20% of the economy on healthcare, when it grows on an annual basis as parts of the state budget, what happens is it starts crowding out lots of other things. And so the decline in spending on education, for instance, at the state level, is in large part driven by the increases in spending in healthcare. The decline in public health, the decline in infrastructure, road and bridges, there's very good evidence that as states spend more on healthcare, they spend less on everything else. Because it is the rare state that says, no big deal, we'll just increase taxes for everybody. Sometimes I feel like I live in one. Oh, I'm going to say. No, but in all seriousness, these are very important and urgent issues that need thoughtful, empirically driven work, but then tied to bold legislative and regulatory action. So the panel today is going to get much more into the weeds and into the depth of this. And I'm going to have our moderator, Erin Fuse-Brown, introduce the panel, but let me take 30 seconds to introduce Professor Fuse-Brown. So Erin, we recruited from the University of Georgia. She is a legal scholar. So most of the people who do work in health policy who are academics are people like me who trained as doctors or people with PhDs. And every once in a while, we find a legal scholar who helps us think about all these problems in a totally different way. I used to go around saying, the government should do this. And then people would be like, what part of government and how? I'm like, through government stuff that governments do. And legal stuff. And spending time with people like Erin, I have come to understand that there are legislative actions and regulatory actions, and there are things that agencies can do, and there are places where they need more authority. And if you actually want to be effective on these issues, you have to understand the levers of government. You have to understand the freedoms and the complexities of government and different parts of government. And that bringing that lens to the scholarship of CAPER has actually, I think, been one of the key reasons why CAPER is having the kind of impact it has. So we were completely thrilled that we persuaded her to leave Georgia and come to Rhode Island. Professor Fuse-Brown is going to lead us on for the next part of the session. Erin.
Thank you for that wonderful introduction and for these fantastic remarks. Jonathan's observation and coining of phrase, the platformization of healthcare, I think, is the perfect image to really set up our discussion today. And I think Senator Warren's call to action really shows that this is really an important, not only emerging issue of health policy, but I think it's sort of, in some ways, the big thing, right? Like it's the thing that's taking up a lot of the dollars. It's taking up a lot of the health system and all of the power and money that flows through the healthcare system. And so I think it's a really important topic of vertical integration and vertical consolidation that we're talking about today. So I'm delighted that we have some fantastic experts to join us here today. The first expert is Christopher Whaley, who's a professor with CAPER at the Brown School of Public Health. He's a health economist, and he's really, one of the foremost experts in healthcare markets and consolidation. And then we're joined as well by Hayden Rookle, who's a health law and policy fellow. He's an attorney like me, so we're trying to build the bench in terms of the people who are legally trained but working with the empirical researchers to shape policy. And Hayden is one of the premier thinkers on this area. We are also we're delighted to be joined by Aditi Sen, who's the chief of the Health Policy Studies Unit at the Congressional Budget Office. She's also an economist and an adjunct assistant professor at Johns Hopkins Bloomberg School of Public Health. And then finally, but not least, we are joined by Connor Sheehy, who's the director at Levitt Partners, where he provides consulting services to a range of various healthcare service stakeholders. So we have, some fantastic insights from our panel, and we'll sit down and I'll take it from here, from the chair. All right. So I think what we're going to do is we asked our panelists not to engage so much in prepared remarks, but to really just structure this as a conversation. And I also wanted to remind everyone that you see on your table, there are colored note cards. And so we do hope to have a robust discussion at the end of sort of the initial panel discussion, where audience questions will be entertained, but rather than sort of navigate a tight room with walking up to a mic, please write down your question and pass it There'll be to Jared, who's in the back. He'll go around and collect questions, and we'll hopefully have some time at the end for questions and comments from the audience. All right. So first, we'll start with Chris. So, one of the things we wanted to just talk about, I think we have a sense, but is sort of what do we mean when we say vertical integration? Like, what does it actually look like, and how do we define it? How do you think about that from an economist's point of view?
Yeah, so first off, we're not in Providence, but thank you everyone for coming to Brown. And so I just want to take a bit of a step back. And when I think about the healthcare system, I really think that there are really three distinct waves of consolidation. And so if we go back late 2000s, or early 2000s, late 90s rather, we saw a bunch of hospitals try to get bigger to compete with insurers. They were trying to get bigger and have direct hospital or forming these huge mega health systems or huge insurer systems as kind of huge conglomerates that are horizontally consolidating. And we kind of know how to think about what are the impacts of that type of consolidation and how to actually measure and assess consolidation in that manner. There's only so many hospitals you can buy. Insurers have a limit to how big they can get. And there's also been a lot of regulatory pushback on those types of consolidation. And so about 15 or so years ago, we saw really the first wave of vertical consolidation. So this is really a hospital going out and trying to control at least one portion of the supply chain, namely physicians and in particular primary care physicians, and saying, look, physician, there's a lot that you do. I want you to do more for me, and so I'm going to go out and I'm going to acquire you as a physician, and I'm going to, whether it's change referrals, change how you use electronic health records, or just negotiate prices with insurers for you. I'm going to do all that for you, and we're collectively, although me as the hospital are probably get most of it, we're going to split some of the proceeds. And we've gone from that type of consolidation from going from about 20 or so percent of physicians who worked for a health system to now about 60 or so percent. And so that's really just fundamentally changed physician markets. And where we've gone in what I think is the third wave of consolidation, where we're, I think, really kind of smack dab in the middle, is a much broader interpretation of vertical integration. And this is almost less of a pure vertical relationship, but more of just a general corporatization of care. And this is led by, say, PE firms going out and acquiring physician practices, although as well as many other portions of the supply chain or many other aspects of providers, as well as we just heard, extending much beyond physicians. And this has really been driven by insurers. And this includes whether a insurer owns physicians, where we've seen just a huge explosion in growth, as well as things like PBMs and other aspects of the delivery system.
Absolutely. Well, thanks for that sort of definitional framework, because I think a lot of times when we hear about, we sort of have come to understand that horizontal consolidation generally is bad, right? Like I think most people agree that's pretty well established. But oftentimes vertical integration is sort of, again, it's ambiguous. Some people say, well, it's going to be great for care coordination, it's going to be great for quality, it's going to be great for patients and convenience, et cetera. So in terms of this idea of vertical integration and moving towards consolidation, what are the big market trends, Hayden, that we're seeing, and what are some of the policy concerns that how we should be thinking about this when we think about, why should we be caring about, is this just advancing pro-competitive efficiencies and care coordination?
Yeah, so I'd pick up on Chris's remarks and others to just reiterate that I think we are in this phase of seeing kind of a restructuring of many different healthcare markets and a change in kind of the nature or the process of competition, how firms are operating in various aspects of the healthcare delivery system. I would echo Jonathan's remarks that we are seeing a number of especially big players seizing control of various aspects of the healthcare delivery and payment system and really integrating in every direction. So to echo the same point, essentially acquiring customers and suppliers. And the concern here, the risk here, is that consolidation is being undertaken to essentially fortify market dominance in these key aspects of leverage throughout the healthcare system. Insurance is a good example here, but there are many. And this sort of integration can not only fortify the market dominance in those key aspects, but also allow these big integrated firms to essentially capture rents in the markets that they acquire into or integrate into. So just to put a little bit of detail on, sort of these abstractions and metaphors we've been using here, insurance is a big area where we're seeing consolidation from the biggest payers, particularly ones that participate in public programs like Medicare Advantage, United, Humana, CVS, integrating into the drug supply chain. So all of them, all the biggest payers now own PBMs. The 3 biggest PBMs are owned by payers. It's not just that, though. They're integrating into actually pharmacies. So the PBM dictates to a large degree where a drug gets picked up. All of those firms are now acquiring pharmacies, owning bricks and mortar, infusion centers, mail delivery, specialty pharmacy. We're also seeing those same firms now own medical practices and care delivery. A lot of emphasis on primary care, also multi-specialty care, and then the post-acute process. So it's a very deliberate strategy of these biggest integrated payers to own home health, hospice, some of the convener entities that dictate basically the path of care post-hospitalization. And we're also seeing some other, and this is getting increasingly more and more coverage, we're seeing some other forms of integration that pick up on these same themes. So the 3 biggest drug wholesalers that distribute most of the drugs from manufacturers to pharmacies and physician practices. This is another market that's very consolidated horizontally. 98% of it is owned by a sort of, there are a number of big 3s in the healthcare system. This is a different one. We've been hearing a lot about the PBM big 3. This is, AmerisourceBergen, Cardinal, McKesson. But it's not just that they're distributors now. They're integrating in both directions as both sort of de facto manufacturers, as labelers of drug manufacturers, but more so actually acquiring the pharmacies and medical practices that they deliver their drugs to. So McKesson is the biggest one here. McKesson now is actually the largest owner of community oncology nationally. And the other 2 big drug distributors are now acquiring specialty physician practices, particularly the ones that distribute high margin drugs, oncology, rheumatology, gastroenterology, urology. And so we're really seeing this same sort of trend here. You see a similar thing in the dialysis space, another area that's mostly actually paid by Medicare, very horizontally consolidated and has long been actually by 2 firms. But if you talk to competitors in that space, it's not just that those firms provide the dialysis, they also own the equipment that is required to operate a dialysis center. So you're in a difficult position if you're an independent. You're reliant on that same firm. That's your horizontal competitor, but also is the one from whom you've got to acquire the equipment. So the theme here is that getting to the question about kind of the concern here is a whole range of anti-competitive conduct to fortify a market position and potentially to leverage rents in other parts of the market. MA is what's been discussed the most. We've seen these big payers, for example, vertically integrate, acquire practices that allows them to increase payments from the government. A lot of our research on our team looks at risk adjustment payments, a wonky sort of technical issue. But the strategy looks like from MA payers is to acquire physician practices that allows them to increase payments, subsidies from the government. And then if they can own all the providers that they pay for, they can capture those rents down the system. So that's the concerning model. Of course, there's another plausible outcome here, that this is just an efficient operation, capturing double marginalization, all the things that we hear about might be beneficial from vertical consolidation. But I think we need to be really rigorous about sort of which of those is occurring. And I think we're seeing a lot of evidence that it might be the former. And it gets to the point about trying to map out what's going on here.
I want to turn to DT and Connor, but on just the issue of evidence, maybe Chris, do we have a sense of what the evidence is of vertical integration or consolidation on patient access, costs, the things that the outcomes we really care about?
So on the kind of traditional side of vertical integration, that's hospitals acquiring physician practices, we have a decent body of evidence that this leads to higher prices, worse outcomes for patients, and further barriers to getting care. And we also know from a lot of evidence that this is disproportionately borne by high needs patients. And so if you're a health system, the easiest patients to take care of are the healthy patients who just, frankly don't have to do as much. And so that's where the attention goes versus the harder to deal with and more complex patients. And so if we're thinking about equity in the healthcare system, this is something that is critically important. For the newer types of vertical integration, we, to be frank, don't have a ton of evidence on either direction. So I think if we are particularly concerned about what adverse impacts are, we should tread very lightly in progressing these, because we know that there's this potential of outcomes happening. And even though we haven't necessarily monitored them, we know that they're probably lurking behind the corner. And I would say one of the reasons that we don't have great evidence is that a lot of these deals are, at least from my read, intentionally incredibly opaque. And just for example, United Healthcare says that they employ about 10% of the physicians in the country, about 90,000 docs. When we look at very restricted access use data that CMS uses to monitor physician employment, we see about 5,000 physicians working for United. And so there's really no way for these transactions to be designed and structured they are without the intent of being opaque and evading scrutiny. And so as we're trying to map the genome of the healthcare system, I think that's critically important, because we know that these effects are lurking out there, and we have to document them.
Yeah.
And I guess just one other point to Hayden's point too. There might be efficiencies, and we should acknowledge that certainly could be happening. But it's not just efficiencies being out there. Those efficiencies actually have to be passed down to patients in terms of better quality and lower cost. If they're just being captured by dominant firms, then that does nothing for us as patients.
Yeah. Thank you. And so, in order to put a sense of like how does this show up in the larger economy, so Aditi, from a budgetary perspective, how significant is vertical integration's impact when you think about Medicare, Medicaid spending?
Yeah, and I just want to say thank you for having me.
Yeah.
I am from Boston, so I didn't realize I could
Yeah.
get to New England just by
walking down the metro.
metro stops over. So yeah, thanks for the invitation. I'm really happy to be here. So I work at the Congressional Budget Office. Our kind of bread and butter is to think about the effects of various trends and policies on the federal budget. And of course, the federal government subsidizes healthcare costs for obviously people who are in Medicare and Medicaid, the public programs, but also for people who have commercial insurance. And I think, kind of building on what Chris was saying, there's a good amount of evidence that this sort of vertical consolidation increases prices, can lead to, so that's sort of commercial market focus, since prices in Medicare and Medicaid are largely administered, but also can lead to sort of more intense services. So that has effects on people in Medicare and Medicaid, and also can lead to sort of shifts in where care takes place. So, previously a service would be in a physician's office, one price, and when the physician's office gets bought up by a hospital, now that's an outpatient department. And sort of in both Medicare and in the sort of public and private programs, those are more expensive services, right? So, there, I think when we are thinking about kind of growth in Medicare and Medicaid, we are thinking about kind of two pieces. One is how many people are going to be in these programs, right? So enrollment, that's affected by current policy, what we think is going to happen with future policy decisions, demographics, and then there's the kind of per enrollee subsidy that the government is paying. And that's where you see trends like vertical consolidation coming in and affecting that kind of amount, the price, basically, that the federal government is paying. And those kinds of trends are built into CBO's sort of baseline projections for Medicare and Medicaid program growth. So it's not sort of explicitly broken out, but it is, we expect the trend in vertical consolidation to continue, and that's sort of implicitly built into our long-term sort of budget projections. And I think we can come back and talk about kind of how we build it into cost estimates and sort of more specific policy estimates.
Well, thank you for that. So, it's important to think about like how this like type of vertical integration shows up, as you said, somewhat differently in the commercial market versus the Medicare and Medicaid space. And then, one of the things is, then there's the industry. So Connor, from your vantage point, what are the biggest strategic and operational drivers and incentives that are sort of driving all of this trend toward getting bigger?
Yeah, Erin, it's a great question, and I also want to say thanks so much to Caper and to Brown. Even though I was a UVA guy, I'm very, very happy to be made an honorary Ivy Leaguer for an hour today. I think one thing I should mention, in addition to the typical caveat that I'm speaking only on my own behalf, not on behalf of any of our clients or Levitt partners, until a few weeks ago, I was working on Capitol Hill. So I spent 4 years on the Senate Finance Committee, where I was the co-author on the GOP side of, I think, the most comprehensive pharmacy benefit manager reform oversight legislation that Congress had ever undertaken. And we kept trying to get it to the finish line. It underscored, I think, a point that Jonathan made in his excellent remarks about how quickly things change. We wrote this bill back in 2023, and I think it was pretty prime time ready by that summer. By the time we were trying to get it done at the end of last year, and we were informed that our colleagues in the House Republican conference felt that it was too many pages and wanted to take a kind of Harold and the Purple Crayon approach to policymaking where everything could be in a little kid's book, which again, that killed that proposal. In that short period of time, we'd been seeing the newfound emergence of these private labeling arrangements, which looked nothing like what private labeling arrangements had looked like in the past. We didn't have any sense of what the fee structures looked like with respect to those new acquisitions, or in some cases, the launch of these new entities. Even in the early drafting days, we'd been hearing a lot about these offshore rebate aggregators, these new entities that were nominally calling themselves group purchasing organizations, but looked nothing like conventional group purchasing organizations. And so by the time we were still enthusiastic about getting this bill done, and unfortunately Congress has not been all that effective at doing much of anything, and that was true for much of my time on the Hill. But the reality is we're in such a crazily evolving landscape that I do think one word of caution, this shouldn't halt our progress on these issues, but it should inform the process, is just that the legislative branch is reactive at best and sluggish and inactive or counterproductive at worst. I think we, more often than not, the general public seems to agree it falls into that latter category. I think it's by and large, even the pharmaceutical industry, which never has particularly high marks from the public, does outrank Congress, and particularly the House. As a Senate staffer, as a former Senate staffer, I have to say the House of Representatives is always the lowest, which we took a lot of pride in. We would be at like 13% to their 10%. But the reason I start off with that is the reality is that the policy landscape can have far-reaching effects, most of which are unintended, and very few of which are actually hitting their targets. And I think in the case of vertical integration, part of the reason that industry stakeholders are able to go to Capitol Hill and go to the administration and in some cases go to the public and say, hey, we're doing this because efficiency, is that they are dealing with constant headwinds and burdens and problematic or outdated policies. And I would say, by and large, federal policy has done more to contribute to consolidation than to combat it. The only time I can think of a real FTC intervention in the past few decades that had a meaningful impact on vertical integration long term was back when branded pharma companies in the 90s and early 2000s were trying to buy up PBMs, which, again, so it was almost like they became the model then for the Uniteds of the world. But the Uniteds of the world were able to get away with it. But the FTC came in those cases and said, you guys have claimed that these are David and Goliath battles. Both sides always claim that they're David. No one wants to be Goliath. No one's gone to Bible school and recognizes that David wins. But I think most of what we see now is like Goliath versus Goliath, and it's the same person on both sides of the table. But the FTC did put its foot down in the early 2000s and said, like, Merck Medco cannot be a thing. You don't get to market these products, negotiate with yourself, and dictate how patients are steered to different products. I think it'll be interesting to see how that impacts FTC and DOJ policy moving forward. But that was a rare case. We've generally not seen interventions like that. And with respect to pharmacies, vertical integration of pharmacy services has been going on for years. The key now is we are relying more and more as consumers, as patients, on specialty distribution channels, just because specialty drugs, and some of these are miraculous products, that's where we're seeing a lot of the breakthroughs in conditions like oncology and whatnot. It's worth noting for specialty pharmacies, the big three PBMs collectively with respect to their specialty pharmacy affiliates, they control more than 2/3 of specialty dispensing volume, I think by both sales and volume. So that's actually a phenomenon that's been developing for a while. On the retail side, CVS is just the most visible player. And again, I think part of the reason that these vertically integrated agreements and arrangements are so attractive for stakeholders is that A, they've not been cracked down on historically. These are M&A activities that have generally gone through.
Yep.
And that's not to disparage FTC or DOJ, but there has been a perception that there's not a real cop on the beat. That was true under Clinton, and it was true under Bush 1. Under President Trump, I have no idea what to expect. We're all kind of waiting with bated breath to see what anonymous official says something next. But I do think the reality is there are a lot of federal policies outside of DOJ and FTC that also play a role here. Look at the physician fee schedule. Medicare's physician fee schedule, it doesn't just pay on a stagnant basis. The rates have declined in nominal and real terms. They've actually moved in the opposite direction of inflation. Meanwhile, if you're a doc, you can't wave your magic wand and say, I want to pay negative dollars for nursing staff and for personnel for my office. And I'm going to wave my magic wand and fix all the supply chain issues so I can get supplies more quickly and at a lower cost. So the headwinds for the physician fee schedule are a nightmare. And if you look at Medicaid rates, since Medicaid came up earlier, I think a Health Affairs article that was published, it might even have been earlier this month, came out and said that we're now looking at 71% of Medicare rates on average is the Medicaid rate for physician services. It's lower for office visits. So the service that folks think of as bread and butter, I want to go to the doctor, I want to get myself checked out for an annual wellness visit, you're making 68 cents on the Medicare dollar, and the Medicare dollar is going to put you underwater. And then folks say, well, it's really all about hospitals getting overpaid. MedPAC came out this year in their March 2025 report and noted, if you're a large health system, you've probably got comfortable margins, you've benefited a lot from horizontal integration such that you've got a lot of power across the negotiating table. That is not true for most hospitals. Hospital closures are well outpacing new hospital openings. And again, Medicare payments for hospital outpatient and inpatient services are well below costs. So when I look at all of those factors, the economic incentives are very much in favor of how can I benefit from scale? And that's to say nothing of the thousands of various different quality reporting requirements. And I'm dealing with commercial payers, Medicare, Medicaid. I'm dealing with all sorts of state legislation that's saying you also have to report on X, Y, and Z. The SEC is telling me I have to report on those same data points, but differently. And so again, a lot of that stuff could boil down to good intentions. We all want better value-based care. We all want to see more participation in alternative payment models. But the reality is, if you create extensively excessive reporting burdens, things like conditions of participation, which always gain pages, they rarely get shorter, they rarely get more targeted, and these are hospitals that generally don't have big margins to invest in the types of AI and other technology that can bend the cost curve on that side. And then you're looking at declining Medicare rates, declining Medicaid rates, the constant prospect that states, even in the absence of federal payment changes, might step in and say, hey, we're actually going to beat that Medicaid rate down even lower. And I think that's especially top of mind this summer for many of our providers. It doesn't justify the practices that stem from excessive vertical integration. And again, I'm not here to defend that stuff. I've spent and arguably wasted years of my life on PBM reform, on oversight in terms of wholesalers and other intermediaries. I believe in all this stuff, and I think a lot of stakeholders across industry do as well. But if you don't understand those core drivers, then you often have the wrong solutions. But like, last thing I'll say on this front, because again, I have much more esteemed colleagues to my right, but it's worth noting, for instance, that anytime you look to new transparency requirements as a solution, you are adding paperwork hours for any compliant facility, compliant physician. You're adding hours of time and energy, sometimes in areas that are not their expertise. You're going to make it more and more attractive for those folks to want to join a large health system. Or you can't operate an independent physician practice these days without extensive external capital. What, you're going to go with a PE invested model? You're going to go with a managed services organization because that's your only way to stay afloat. So again, none of this is to say, oh, these folks are all victims. This is a complicated, sprawling landscape, but it is to say we need informed, careful, and targeted solutions, and we have to have the humility to recognize that many of the solutions of decades past have actually made the problem worse, even if they look good on paper. Sure, the Republicans in the 90s were very excited about their austerity agenda. They were going to crack down on hospital payment growth. They got us SGR, which physicians hate. Right. And yet, years later, it's, I think, almost unquestionable that those austerity reforms in the 90s actually accelerated the trends towards vertical and horizontal integration. So all that said, I think this is a vital topic. I think there are solutions out there. I just think we also have to recognize the big picture, which is this is not all Gordon Gekko saying greed is good, big is good. Let's try to, give the taxpayer and the patient the squeeze at every turn. A lot of this is rational economic behavior and a desire to avoid an excessive compliance burden that grows monumentally every year.
So, Hayden, you've written a lot about some of the policy and sort of levers, gaps, and also the sort of administrative burden that's driving scale and vertical integration. So, I'd be curious to hear what you think are some of the most promising or, levers, but also what some of the gaps are or what things need to be fixed.
Yeah, I would echo the point, certainly, that when thinking about payment policy is crucial here. And, we have to be thinking about how consolidation, how we want to structure markets, how essentially the law wants to allocate power through our healthcare system is really what we're talking about here, through the prism of payment policy, understanding that Medicare dictates so much of it. And in some ways, I actually think we have been thinking about it this way, just in a pro-consolidation way. And maybe I'll diverge slightly from the comments here, and I would argue that for the last 2 decades, certainly, and maybe even the last 4, we actually been undertaking a deliberate strategy to promote vertical consolidation. The concept, starting with Medicare Advantage, and then picked up, by Democratic policymakers through the value-based payment movement, has been to collapse this distinction between the insurer and the provider. We've had this idyllic model since the 80s of a fully integrated system. And I think what we've seen here is exactly that. We thought it was going to be Kaiser, but it's Optum. And we've, again, through the Medicare Advantage program, which is absolutely ballooned, we've not only subsidized, but we've massively over-subsidized these plans to go acquire providers, take them to risk. That's been the whole idea, is that providers are going to become risk-bearing entities and essentially manage the utilization through this is essentially a form of private rationing or private management of total utilization and total cost. That's been the model we've pushed for. In an incredibly bipartisan way. On the Democratic side, it's been more directly through fee-for-service, pushing risk directly onto providers. These are all forms. This is inherently, definitionally, actually vertical consolidation. That's the point. Providers assuming the risk-bearing function. And I think that imposes a whole host of burdens on small providers that I think we really have to think hard about. When you pair that with all the micromanaging of the quality metrics plus this risk-bearing function, I think policy's made it really difficult for disintegration. And I think it's worth noting that these experiments, both in ACOs and with value-based payment, and in MA, haven't worked on their own terms. MA is significantly more expensive than fee-for-service. ACO is about break even. But we're introducing a level of complexity that's difficult for small providers to exist. And and is creating a whole host of incentives around gaming, financialization, capturing rents. So I think we really have to think hard about whether we're moving in the right direction from a payment policy perspective, and whether it would be more wise for us to radically try to simplify the system and think about what sort of market is going to be structured when we think about a given payment policy. Chris is, we can talk about site neutral, 340B, like all other things that folks have talked about. But I would say the animating paradigm here of moving physicians to risk seems to be the solution that folks seem to continue to coalesce around. I think we really got to think hard about whether that's actually the right strategy for payment policy. I'll stop there as one solution being payment policy. There are obviously another legal ones and others.
Yeah, Aditi, we kind of talked a little bit about this before, but in terms of, the modeling exercise of how do you think about these trends and the long-term fiscal effects of vertical consolidation, what assumptions about behavior by the system, either health systems, health payers, providers, and what are your assumptions there?
Yeah, so I think I would start by saying that we need a lot more evidence on this, right? So basically every cost estimate that CBO puts out, we will take a policy, look at it, and we think about behavioral responses for every policy, right? So we look at a 10-year budget window, we call it. Connor knows well. And so we're not, in many cases, if Congress asks us for it and we have the data to do it, we can look further out, and we do that. In a lot of cases, we don't have the data, and that is a limiting factor. And so, I think since this is an academic event, and I'm no longer in academia, I can just say we need more evidence. So keep doing the research. I think you take you mentioned site neutrality, right? So you take a policy like site neutrality, we would look at it and say, okay, there's a lot of different flavors of site neutrality, right? It may just be a small sliver of services, it may just be one payer, it may be much broader. And so we would kind of assess not just the sort of effects on the directly on payment from that change in policy, but also think about these questions like how are providers going to respond to that? How much of their business does it hit? If it's a Medicare change, what's the likelihood it's going to spill over to commercial payers? What does that imply in terms of how much of their sort of book of business is going to be affected? And then in turn, what do we think is going to happen when our providers, certain kinds of providers, going to respond one way, or different kind of providers going to respond another way? So we think about kind of every level of behavioral response, and I think in a lot of cases we don't have the evidence that we would like to have. And so this is, just sort of another call for more research and more evidence.
Well, and then to that point, Chris, what are the data wish lists for researchers to produce the evidence that Aditi is talking about?
Yeah, so as I highlighted earlier, we really we just know the tip of the iceberg for the new forms of consolidation, and so I really like the platform analogy, and we just have a glimmer of insight into what's happening with the platforms, and as I said earlier, at least my read of why we only have a glimmer when in many other aspects of health, and we've got a ton of healthcare data, and we know a lot about the healthcare system, is that these deals are intentionally structured to be incredibly opaque and to prevent us from the research community, regulators, as well as folks like the CBO, from actually understanding what the true impacts are. And so if I were just to put on my suspicious hat, if you will, I would read that as to say, well, we should be more concerned, and that should just redouble our efforts to understand this type of consolidation and just this really restructuring of the healthcare system.
And so, I don't mean to point out a tension between the commentators on the panel, but there's every time there's a new transparency effort, and I'm responsible for calling for more ownership transparency, for more other types of transparency, so that researchers, regulators, policymakers and the public have a better understanding of this sort of iceberg. There is the sort of natural consequence that there's a compliance burden or there's an administrative burden. So how do we decide what forms of data transparency, who should be getting this? Is there sort of a way to do this well so that we can generate the understanding that we need, the data? And are there ways to do it that will just create backlash or actually more consolidation?
Yeah, I think it can be done well. I will say this. In my time on the Hill, and I was there for roughly a decade, every year I was more and more amazed by how much good information was getting out there because of effective transparency efforts. Part of it was we had incredible resources like CBO, and the Hill likes to be far too unkind to our friends at CBO because they'll give scores that folks don't like. But the reality is the Congressional Budget Office is one of the best educational resources and economic resources for policymakers, in part because the average policymaker, it's to say nothing of members, even a staffer, they don't have time to pour through the evidence and the research that's out there. And so I think CBO, with a lot of their analysis, does a terrific job of going through it. But also, there's a lot of information that ASPE, I think ASPE still exists. I don't know, actually. I guess now that I don't work on the Hill anymore, I can say I always really liked ASPE. I hope they stick around. I hope Congress ensures that these research entities actually do continue to play a critical role, in part because I think having information sent to the department or agency level is often the best way to do it with respect to, granular, potentially even identifiable in some cases, data. And then I think it makes sense to have other entities within the government who are well equipped to, on a national level, either on their own or through contracts and subcontracts, who are able to make sense of those numbers and to make them meaningful. And so I think there are countless examples of where that's been done particularly well. And I think there are very few, bread and butter payment level information, data points that aren't useful. And there are gaps. With respect to supplemental benefits and Medicare Advantage, for instance, look, those are really attractive to consumers in a lot of cases. That's what we see from polls and surveys. The reality is MedPAC's pointed this out. Capitol Hill's pointed this out on a bipartisan basis. There is virtually no data that goes into CMS with respect to utilization or out-of-pocket costs with respect to a given supplemental benefit. And the categorization is actually it is lacking, right? And folks, I think folks at MedPAC and in other spots keep trying to say, okay, can we go through encounter data to try to get a back door to this? It's a really bad fit because that data is just not naturally going to have what they're looking for. And yet, as we think about Medicare Advantage and its value proposition, as well as areas where we could responsibly make it more affordable for the taxpayer and to serve high quality benefits to seniors, we actually need to know a lot more about supplemental benefits. And candidly, the plan ecosystem is so concentrated, and it's becoming more concentrated by the day. And those are companies that are known for, and their selling point is claims processing. They sell copious amounts of data services to other stakeholders. Sometimes they sell data services to manufacturers that the manufacturers don't want. They do pay for them because they say, well, that's a piece of the contract. But all that is to say, plans are actually well positioned, especially large plans, to produce and submit that data. And I think the government can take good advantage of it. But I think with providers, for instance, we can do both things at the same time. A lot of the quality reporting is so sporadic and it's a patchwork across different payers. Let's explore a bit more standardization and ways to try to streamline some of that, because that's also better for value. We can actually get a sense of what that landscape looks like. So to me, that's a clear area where you can streamline and you can standardize to alleviate burden. I think with ownership transparency, the last and only flag I have on that is states are taking diverse approaches to this. I know with Massachusetts, for instance, obviously you've got a pretty robust legislative effort that's not focused as much on Mother May I pre-approval, but that is looking at, okay, let's have a data reporting with respect to these types of transactions. What I noticed about Massachusetts' approach is a lot of the burden is on the investment side, and it's actually on the side that has expertise and line of sight into, what these really complex economic transactions look like. I'm much more comfortable with those folks who are routinely submitting, copious SEC filings and who have all been trained in this specific field, right? They know finance. I'm actually very comfortable with a discussion around more streamlined and, frankly, more meaningful reporting around ownership from that end. I think where I get nervous is, do you want to have independent practices trying to fill out the types of forms that, and frankly, CMS has tried this in recent years. This does exist in some form now. Like CMS is conflating all these, and I say this not to disparage them, but they're saying like PE, REITs, venture capital, public corporations, they're all basically the same, and we're going to call them all private equity. And then, right, like that's what the skilled nursing home transparency rule did. And they said when they got comments saying this is inaccurate, they were like, no, we think they're going to have loopholes that they're going to get through otherwise. So again, a lot of this stuff, maybe CMS is not the best suited for ownership transparency, but more importantly, maybe the hospitals and docs are not best positioned to be engaged in compliance with reporting on transactions with arrangements that they don't have a lot of line of sight or experience into. And I don't know that CMS is going to put out as meaningful a report on that component as certain other federal agencies that have that level of expertise. Whereas I would love CMS to have the data needed to put out more reports on things like supplemental benefits or implications of vertical integration when it comes to the 15 subsidiaries of a PBM and what that looks like for a given transaction.
Chris, I was wanting to see if you had any, thoughts or response on sort of data, transparency, and.
So I agree that a lot of the quality, especially reporting measures, are both incredibly burdensome and also complete garbage. And so, there's no purpose. But if you are if you build a Medicare system, you are supposed to report the tax ID of the group that owns or manages your practice. Many providers just don't report that, and so it doesn't seem that burdensome to file your taxes, especially if you're getting money from Medicare. But then also on the price transparency side, I also think that's not necessarily that burdensome. So if you have the wherewithal to send a patient a bill, then presumably you have the wherewithal to know what your prices are, and that's something that to put on an Excel sheet doesn't seem super burdensome.
All right. Do we have? Yeah.
Can I also just make a plug for, I think something that, at least, in my few years in academia, there wasn't a ton of focus, and certainly as economists, we are not trained to do sort of case study type analyses. But I think, when we're trying to think about how do hospitals respond to 340B incentives, and how is a provider practice going to respond to a particular kind of vertical integration, I think there's a lot that we can learn from kind of descriptive work. Of course, it can get to be sort of more anecdotal, but I think a really well constructed case study. Chris has done some work looking at specific health systems and how they respond to different incentives, and I think that's all really valuable in a case where you may not be able to do a full national, sort of really gold standard study, but there are things to learn from how kind of specific systems are responding to different incentives. That's really helpful.
Yeah.
Our case studies are gold standard.
that I'm sure is true. That's why we use them, Chris.
So we do have I'm just there are some great questions. I don't know if we're going to get to all of them, but hopefully I'll sort of pick some at random, and then hopefully we'll pull out some thoughts from the panel. So I think this is probably for Hayden. What are the threats or risks of the big three PBM GPOs, and what should we do about it?
So, I think the big threat here is this model of sort of competition that we've described here, where the PBM is effectively using its power as an intermediary, sort of a subsidiary of the insurance company, to self-preference its own companies and not necessarily drive a more efficiency to its own mail order pharmacy or specialty pharmacy, but essentially with control over that entity or over that point in the delivery system or the drug supply chain, be able to steer drugs, particularly ones that have higher margins, in the drug payment space is crazy. Just the ways in which pharmacies, for example, will lose money on a bunch of drugs, and then there's a select few, particularly the specialty drugs, that will that they'll get massive margins on, and will essentially sustain their viability as pharmacies. And so the threat here is that if you have the intermediaries, the big three, owning these, and if they can control where that drug gets dispensed. And they own the pharmacies, that they will steer away from obviously unaffiliated competitors here. This has come up a decent amount in the FTC's report. To harp on the theme of transparency, there's real difficulty in understanding what's going on here. A central question in these vertical consolidation stories is whether these are efficiency enhancing or not. In other words, is the intermediary, the essential sort of intermediary, paying their own subsidiaries more or less? It's like a basic question, but we'd want to know what's happening.
And it does seem to be more.
Right. So there's select evidence. There's evidence from the FTC that says more, and then you get a report from industry that basically says no. But if you dig into it, they say, we can't actually tell you what we're paying ourselves. It's difficult. Right. These are intercompany transfers, so we actually don't know. In the Medicare Advantage program, it's the same thing. We couldn't tell you right now. The MA program is not structured to tell you whether Humana, when they own a practice, is paying their own affiliates more to basically move profits over to the other side. So the PBM story, it is this same story that we're seeing everywhere, where is this vertical consolidation a game to move profits to their own affiliates? And if we're concerned, for example, about independent pharmacies being able to persist or competitors being able to enter, we have to think about whether we can get that data and police it, or whether, again, we want to think about the process of competition in these markets and whether it's a smart thing or not to set up a market, to make a rule in a market, as government is always doing, whether to have the PBM and own its competitors in this quasi but not fully closed system. And we could have rules, for example, that Hawley and Warren are introducing that just says it's structural separation. Yeah, Arkansas is doing the same thing. So you're starting to see bills come up that are trying to, and this is not a novel sort of intervention. We don't tend to see these things in healthcare, but in other industries historically, highly regulated, highly monopolized industries, there's a whole toolkit that's been brought to bear around structural separation, profit caps like we have with MLRs, but often paired with structural separation, rate regulation, ownership and governance requirements, like all these things that we've seen dealt with in other industries. I think we need to be thinking about in healthcare. Antitrust has always been a big one there, and I want to credit the Biden's DOJ for advancing, and I think really relevant ways, and I'll stop. Antitrust doctrine. Right now, for decades, as Connor mentioned, the entities in the antitrust space have basically said, look, the DOJ is going to come after us if we merge horizontally, but it's a free pass vertically. There has been, courts have tended to look at these transactions and made presumptions about efficiencies, and generally been permissive of forms of vertical consolidation. What we're seeing is not only a resistance to those presumptions, but also a mapping, a description of the way competition is operating in these markets like big tech, where it's not just a siloed vertical consolidation, it's ownership of the entire ecosystem, and whether understanding that process of competition, that's what we've seen some success in the big tech cases. And I think we should be thinking in similar ways when we think about bringing antitrust to bear with these big platforms in the healthcare space.
Chris, did you have?
Yeah, I just have a quick example to add to that that's a on the ground concern. So the state of North Carolina provides insurance to a bunch of public employees and teachers in the state. Like most employers and purchasers, GLPs are their number one cost driver over the last couple of years. There are two main GLPs in the country, and so what they said is a perfectly reasonable thing. We're going to put the two against each other, and we're going to go with the one that offers us the lowest price. And so they went to their large national PBM, who's integrated with their pharmacy, and said, go ahead and do this. And the PBM came back and said, well, if we do that, our rebate at our own pharmacies is going to be half. And so we are not even going to, even though we're your agent and you're paying us to get you the best deal, we're not going to do that for you. And so as a result, the state had to say, well, we just can't cover these drugs at all. We're not able to navigate through the system. And so individuals and patients in North Carolina just aren't able to get these drugs unless they pay thousands of dollars per month for them.
And the consumer doesn't get any of the rebate. Like that's
the consumer
other
doesn't
issue.
get it. Yeah.
Vertical integration combined with the horizontal integration in this space, with respect to the PBMs, it's worth noting because they're the payer too, in most cases, not albeit an example like North Carolina's, but they're able to control the entire business model. They don't have to be responsive to consumers because the three all operate in accordance with the same type of rebating system where they say, we're going to pocket larger and larger rebates, but we're more and more often going to charge the consumer based on a percentage of the sticker price. We would never pay the sticker price, but Johnny sure as heck will. And guess what? If Johnny says, oh, I want to go with a different plan, the other plan's going to say, we're also going to charge you based on that sticker price. It's big bad pharma. They're out to get you. Meanwhile, they're getting, with insulin, it was like 85 or 90% discounts per unit. And yet again, consumers were rationing their pill, they're rationing their drug, or they were abandoning their prescription because high deductible plans were becoming more and more popular. By the way, high deductible plans, another innovation of these same large conglomerates. So it's worth noting, like, in an uncompetitive market that's also vertically integrated, it's opaque at every level. This is already a complicated sphere. If I'm a patient, even if I'm super savvy, I can't look up what the rebates look like for my drugs or whether my plan's getting a good deal. I will have more and more drugs excluded, and I don't have meaningful choices, so I can't hold these payers accountable because
Connor,
there are three of them.
So Connor, it doesn't matter if you know the rebate because you're never getting it.
You're not going to get it.
It doesn't matter if you know exactly what it was.
Nobody knows what it is anyway.
So we only have a few more minutes. So, okay, we've painted a pretty a gloomy picture here. What are some potential low-hanging fruit? No, it doesn't have to be the silver bullet. Like, I'm using all sorts of metaphors here. What are some things that we could do in the short term to deal with some of these problems, either the incentives, the upstream incentives, or to just deal with the system as it is, to put guardrails around protecting, patient care, again, reining in spending. What are some things? I'll just lightning round. I'm going to go down the line.
So one policy option would be site of care payment differentials are the driving force of hospitals acquiring physicians. If we were to have a more sensible payment policy, that would slow the acquisition of physician practices. It would substantially lower spending. I think CBO's estimated $150 billion just in the Medicare program alone, and it would improve the quality of care for patients.
Another easy one would be getting control of the Medicare Advantage program. Estimates now it's overpaid about 20%. That's equal to $80, $90, $100 billion a year relative to fee-for-service. That's direct public money going to insurance companies that are engaging in basically all the conduct that we've been maligning here. So if we are concerned about that and just completely privatizing our Medicare program and not having a public option, I will just note a concerted effort was made in Medicare Part D. So when we passed the drug benefit, there's no public option. There's no fee for service for the drug benefit in Medicare. It was completely privatized from the beginning to insurance companies. We said, let's have insurance companies administer this benefit. Although the PBMs are a creature of those. We don't have to do it this way. You could just have an original Medicare for Part D. I think that should be part of the discussion as we talk about how to regulate, how to do PBMs. They actually just don't necessarily need to exist. And we see essentially a form of this actually happening at the state level with state Medicaid programs who have followed a similar path actually of privatizing their programs. They're now insourcing, increasingly a number of them are actually insourcing their drug benefit because they've been fleeced by these PBMs. They've seen it. And they just said, that's okay, we'll just do this. We'll just pay the pharmacy when they dispense the drug. So I think that needs to be in the policy conversation, and I would think about it along the same lines of how we think about MA, and again, whether it's been a good idea to delegate basically the cost containment function of our public programs to private risk-bearing entities, MA being the biggest one. I'll save the value-based payment stuff for another time.
Aditi, I know you can't necessarily recommend policy, but from your vantage point, what would be the most helpful, to help CBO do its job?
Yeah, I think I'll just sort of continue this march for sort of smart collection of evidence, not to necessarily add to the administrative burden, to collect it from entities that kind of should have it already, but are not reporting it, or are reporting it in a way that makes it very difficult to use it. So I think, both understanding sort of trends in spending and, that kind of data, but also the sort of behavioral responses to different kinds of policies at whatever level we can is a really important input for us to give the best information we can to Congress.
Yeah, speaking only on my own behalf, I think the best thing that Congress could do would be to enact the beautiful bipartisan PBM reforms that were left on the cutting room floor last Congress. But no, in all seriousness, I think a combination of a lot of these levers makes sense.
Yeah.
And again, all I would say is the site of service payment differential piece is huge and totally agree it needs to be dealt with. I think MA needs both oversight in terms of transparency and regulatory changes. It's been sort of allowed to operate on its own, and I think it's like the cat in the hat if the kids didn't clean up. And so I think that's an important area. And the only last one I would mention as a policy lever is I think this data collection and reporting conversation, I think it with opportunities like some of the RFIs that have come out from the administration and are likely to continue coming out, I think folks should leverage those as an opportunity to talk about where are there areas where we can streamline, where we can standardize, and where we can alleviate undue, unnecessary, or outdated reporting burden, and how can we shift towards picking up much more meaningful data points, some of which are going to require congressional authorization, particularly because a lot of these entities didn't exist when the program was enacted or even 3 years ago. But again, I think in other cases, the administration can probably take steps on its own. So I think there's a way to engage smart in that deregulatory discussion that actually gives you better, more meaningful data that you can do more with, while also mitigating some of the burdens we hear so often about.
Well, I'd like you to join me in thanking the panel for sharing their fantastic thoughts. Invite Ashish back up to give some closing remarks.
Say or go, whatever you want.
Yeah.
They're like, we're out of here. All right, that was a fascinating, super complicated conversation. At times a little depressing, but I'm glad we ended with like, what are things we can do? I want to come back to a point that I made earlier, which I think is important in all of this, which is that we think about payment as a really powerful tool, and we've gotten a lot of payment stuff wrong, and I do think that a lot of federal policy has driven a lot of the consolidation that we see. But we don't spend, I think, enough time thinking about delivery models. We sort of have this idea that delivery just follows payment. But as the underlying set of services that we're delivering has changed dramatically and has gotten way more complicated, at least my personal view is that we're not thinking about that enough in how we design payment models. And so people talk a lot about what is sort of the ideal payment model. And I think you have to ask that question at the same time as what is the ideal way of delivering healthcare. There is no one ideal delivery model. Lots of people do it very, very differently. The other point is something that I learn a lot from one of my other colleagues at Brown, Irene Papanikolaou, who studies these exact set of issues in other high-income countries. And if you think there is a solution waiting out there, you just cross the Atlantic Ocean and land in Europe, and people often say, well, why don't we do just what Europe does? And hasn't Europe figured all of this out? And I always remind people, first of all, Europe is not a country. And second, Europe doesn't have a health system. European countries all have very different health systems. They all have their complexities. And if you grab a random health policymaker in Europe and say, what are your problems? The answer I constantly hear is we have three sets of issues. We have problems with cost, we have problems with quality, and we have problems with access. Like, I've heard that. And every country makes some set of trade-offs across those things. Thinking about the set of solutions, I was kind of dying there at the end. I'm like, give us some ideas. I think there is no question that PBM reform, so thank you, Connor, is absolutely essential, and this is one places feel super bipartisan. I have been struck by the issue of site-neutral payments in the following way. Like a year ago, I testified in front of Congress, and I was the Democratic witness, and there were like 4 Republican witnesses, and you could not tell who was a Republican and who was a Democrat, because we were all like, site-neutral payments, oh, by the way, how about site-neutral payments? It doesn't feel like there's a lot of like daylight among kind of different policymakers, and yet we don't seem to move much on this. And I suspect it may have something to do with the fact that hospitals are always the biggest employer in every congressional district. But I'm not a political analyst, so that may or may not be the case. But the point is, this stuff has been very hard to move. And Hayden, to your point about overpayment on MA, I think we have very, very good evidence. And I saw David back there somewhere who's been doing some of the best work on this, on MA overpayment. And the truth is that there were a bunch of efforts in the last administration. I think at the end, I think this administration is going to take a different approach to MA. We can all identify where the challenges are. I think moving the needle in very concrete ways on policy has been hard. I want to finish by saying these are super complicated issues that in some ways arise from the super complex way that we're delivering healthcare. Some of that is a good thing. We've got extraordinarily expensive drugs. They're also extraordinarily effective. GLP-1s are a huge problem. They're a godsend, right? And we talk about like these biologics, like, oh my God, like, why are we dealing with this? They're saving lives left and right, and we've got to figure out how to pay for it. So these are serious problems, but I'd rather have these problems because they're problems of incredible innovations that are causing real complexity in how we deliver it and how we pay for it. And I do think we can make progress on this. Some of this is political. Some of this is real disagreement about where the action needs to be. And that disagreement is often clarified when you have very good data. And so that's why I think there's still a role for academic institutions. There's still a role for places like CAPER. And there is definitely a role for conversations like this. So thank you all for being here. Thank you for the fabulous panelists, for Jonathan and Jonathan, your argument about the platformization of healthcare has been something that I think has changed lots of people's thinking on this. So thank you for your remarks, and thank you all for coming.